My name is Reiko Emtman. I'm going to be talking about Idaho's new protective placement hold. And I can advance my slide. Excellent. So we'll start just by going over the literal language in Idaho Code 562101. The way that I am going to approach this talk is by comparing and contrasting it with other involuntary holds in the state of Idaho, specifically the ones that pertain to mental health. We'll talk about the implications and limitations of this new code. And then at the end, we'll talk about logistics of what you do if you have someone in your office who you think meets criteria for this hold. So the Idaho Crisis Hold Law, I want to start by talking about what this is and also what it is not. So okay, there we go. Starting with the what, this allows for the temporary detention of an individual to facilitate necessary medical care in the least restrictive setting. And for these cases, that is defined as a hospital or a freestanding emergency department. This law does not include authorization for treatment. So this law makes it so that facilities can hold someone in the facility against their will, but it does not authorize hospitals, emergency departments, medical centers to administer treatment. You would still need consent from either the person or a surrogate decision maker to administer treatment and workup. The duration of this law, so the hold is temporary. The court can only authorize 7 days of involuntary hold, and the statute does not specify or address what happens after the court-ordered 7-day placement period ends. And the presumption is that the hospital would stabilize the patient, arrange for appropriate discharge, or obtain appropriate consent to continue the hospitalization with consent from a guardian or the person receiving treatment. So this is not a substitute for guardianship. It's not a way to bridge over to a long-term care placement. It's really meant to be temporary. And that's in contrast to the mental health hold laws, which have ways to be extended up to 180 days. This law doesn't really have any way to be extended. It's just a 7-day hold that then expires. Who is included in this? So it's individuals who have neurocognitive disorder, the specific diagnoses listed on this slide. I think the important question to ask is who is not on this list. So there is a population that might end up in a crisis situation that would otherwise meet criteria for this law, and that's people with Wernicke's syndrome or Korsakoff's dementia. That's because of the exclusion criteria described as decreased mental function due to inappropriate use or abuse of substances or medications. So there's still a gap in the system where folks with Wernicke and Korsakoff's syndrome don't meet criteria for an involuntary mental health hold, and they're also excluded from this neurocognitive disorder hold as well. So just to look at the types of holds, there are a lot of similarities between a crisis hold and a mental health hold, including the 3 ways that you can be put on one if you demonstrate that you're a danger to yourself, danger to others, or gravely disabled. But the difference is, a key difference is why you're dangerous to yourself, others, or gravely disabled. For a crisis hold, if the underlying reason for dangerousness is that it's a neurocognitive disorder, a crisis hold is more appropriate. If the symptoms are due to an underlying mental illness, such as untreated major depressive disorder, in a person who also happens to have a neurocognitive disorder, you can still proceed with a mental health hold if the primary condition that is causing the safety concern is a mental illness. And then once the hold is filed or placed, the 2 holds play out a bit differently. The crisis hold requires that an examination be conducted by a clinician at the hospital or facility where the individual is detained, whereas a mental health hold requires examination from a designated examiner employed by the Department of Health and Welfare. So in the mental health hold situation, the clinician makes a referral to the Department of Health and Welfare, and then the clinician from DHW decides whether to uphold or drop the hold. Whereas in the crisis hold, the clinician has the authority to just place the hold, and then there it is. Um, Also, it's different how the hold gets terminated. A mental health hold can only be released by the court, whereas a crisis hold can be unilaterally dropped by any examining provider who determines that the person who was initially on a crisis hold is no longer meets criteria for protective custody. So it doesn't have to be the same clinician that placed the hold. It can be just a clinician involved in the patient's care. And starting April 30th, so next month, all hospitals must report crisis holds and emergency placements of patients with neurocognitive disorders quarterly. So since this law is new, it just went into effect in October of 2024. We still haven't even started collecting data on its frequency of use, but that will be reported quarterly starting next month. More comparing and contrasting for the crisis hold versus the mental health hold. So the way that people with neurocognitive disorder end up being a danger to themselves is it's often inadvertent. You know, they wander outside in the wintertime with no shoes or boots and no coat. That makes them a danger to themselves, even though they might not have that intent to harm themselves. Whereas people who are more appropriate for a mental health hold usually meet danger to self criteria by expressing suicidal ideation with plan and intent. Danger to others is common in neurocognitive disorder due to an inability to express underlying unmet needs. So if they're in pain, if they're hungry, if they're tired, sometimes that can manifest as acting out an aggression um, towards caregivers or other residents in a long-term care setting. Whereas danger to others, as used for a mental health hold, usually has homicidal ideation with intent and plan and a specific target. So the danger to others for the crisis hold is more aggression of whoever happens to be there at the time. It's not calculated or premeditated. It's rather like an impulsive reaction to unmet needs or some kind of discomfort that they can't otherwise express. Grave disability is kind of the third pillar of how one finds oneself on an involuntary hold. With neurocognitive disorder, it's kind of indirect, like not remembering to take medications for hypertension because you keep forgetting them leads to hypertensive encephalopathy, or not taking antibiotics for the pneumonia that you were seeing in clinic for last week. Means a progression of the disease and then you get septic. So that might mandate inpatient level care for what would have otherwise been an outpatient condition because the person's not able to care for themselves and administer the medication treatment that they need to themselves. Whereas grave disability for the mental health side usually can manifest as not taking medications for an acute episode of psychosis or mania. You can see people with inadequate nutrition, hydration, not meeting basic needs due to organization, or sometimes severe neurovegetative symptoms. So, if I had to summarize the general traits of who would need a crisis hold due to a neurocognitive disorder, it would be, you know, when you initially ask the question of what brings you to the emergency room today, most patients with neurocognitive disorder can't quite remember how they got there. And if you remind them, oh, well, I heard that such and such happened, their usual response is, I would never do something like that. I would never hurt my wife. I would never, that doesn't sound like me. Whereas the person who ends up going on a mental health hold usually has a reason or maybe 7 reasons to explain how it is that they wound up in this circumstance where they're being involuntarily hospitalized. And I think this distinction is of really significant clinical importance because it's a key juncture to separate who goes to an inpatient medicine floor, which is where you would end up if you were on a crisis hold for neurocognitive disorder, versus who goes to an inpatient psychiatry unit. The treatment and the expectations of those two care settings are quite different, and we want people to be in the place that's best equipped to serve them. So the person with a UTI and delirium needs antibiotics and a good antipsychotic, whereas the person with a primary depressive disorder with a secondary neurocognitive disorder would actually benefit from the group therapy, the suicide safety planning, and having a lot of buy-in to their their new medication regimen and rallying their natural supports and their family around the treatment plan and what their needs are. Exceptions to this hold law. So if you can obtain consent from a surrogate decision maker, be that a formal healthcare power of attorney or someone's legal guardian, then that would make the crisis hold unnecessary. And if the person themselves is able to demonstrate decisional capacity, then they would also not qualify for this crisis hold. I wanted to review implications and limitations of this crisis hold statute. It gives the courts the authority to order the patient or their family or their insurance, maybe not their family, I'm not sure about that one, to pay for the costs of the hospitalization. So oftentimes when someone is hospitalized involuntarily for mental health reasons, the Department of Health and Welfare pays for the hospitalization, whereas here the funding was not part of this crisis hold statute. So while a person is in the hospital, the inpatient social work team could help them apply for Medicaid. But oftentimes it is the case that an admission for a neurocognitive disorder is not approved by insurance companies because it doesn't meet interqual criteria. It's like a very specific set of rules for what health insurances have to pay for when one of their customers on their plan is hospitalized. And oftentimes, dementia, a diagnosis of neurocognitive disorder alone is not sufficient justification to force an insurance company to pay for the hospitalization. So you want to think about costs. And then another thing is the person-centered perspective. This is probably the most important thing, is where would this person best be served? So the model on an inpatient psychiatry unit involves eating meals together with other people in a common dining area. You're expected to attend and participate in groups. Whereas med-surg floors are typically built around a model where the person who's ill spends a prolonged amount of time inside a hospital room. That's the only place they go. Wandering out into other places often causes problems and poses all kinds of hazards and infection risks, et cetera. And then there's also safety considerations to think about these two settings. So some concrete safety considerations. Staff on inpatient psychiatric units are often trained to manage severe agitation.
Reiko, we lost your PowerPoint.
Oh no.
Oh, there we go.
Is it back? Okay.
Mm-hmm. Okay.
So staff are able to safely administer IM medications, and they have really strict protocols on the use of restraint and seclusion. Medical floor staff are less likely to be trained in restraint and seclusion. They didn't really sign up for a job that involves giving medications to someone who wants to have nothing to do with taking medications and who doesn't see a reason to take medications. And there's a longer list of clinical competencies for med-surg staff, and restraint and seclusion training is not always at the top of the list. This does vary from state to state depending on how these laws, the mental health laws versus the neurocognitive disorder laws, are written. And a final consideration for which environment is best for any given individual is interpersonal violence. So there's data from VA hospitals that shows that when you put an individual who suffers from a neurocognitive disorder in an inpatient psychiatric setting, oftentimes the people with dementia are at higher risk of being attacked by other individuals exhibiting violence who may be suffering from a primary psychotic disorder. So there's safety concerns that go every which way, and they're important to think about. So I will kind of wrap up with the logistics. If you find yourself needing to file a crisis hold, you would complete the application for protective placement of neurocognitive disorder, and it's a specific form that needs to be filled out. You then fax it to your local county prosecuting attorney's office. That form is posted to the ECHO website where you registered. And then you can't forget to drop the hold. So if you admit someone who's on this type of hold, somebody has to drop the hold. So it's on the hospital inpatient team to make sure to drop the hold and work with the court to verify that it's been dropped. And that is different. It's a different form if you're trying to file an involuntary mental health hold form. That has a different title. It's a different form on the website. It also needs to go to the same place, your local county prosecuting attorney's office. And then the designated examiners are the ones who fill all the paperwork and complete it to drop the hold. So you as a clinician are not responsible. So the biggest change is if you're using the crisis hold, you as a clinician have to drop the hold as well. In my final moments, I wanted to just look at what our neighboring WWAMI states do. So Alaska basically includes neurocognitive disorder in their mental health hold laws. And so they often see individuals with severe agitation secondary to dementia winding up in their state psychiatric mental health hospitals. That is not the case in Washington or in Idaho. That's not where people go. Washington and Oregon, Washington's is my favorite. It's kind of wishy-washy. It's like, well, you can't not put someone on an involuntary hold because they have dementia. Um, but also maybe you could. So sometimes it's used. Washington has a number of inpatient geriatric psychiatry treatment units that do accept folks with neurocognitive disorder and behavioral disturbance. And so sometimes this can be a way to get those folks hospitalized at those specialized treatment facilities. Oregon, it wasn't really clear to me where people end up, but it does seem to be separate. So I think Oregon is probably more similar to Massachusetts, where I did my fellowship training, and they have special facilities, long-term care facilities like SNFs, who are well equipped to manage highly agitated individuals for the long haul. And then Montana has some proposed changes that are going to be implemented in July of this year. Currently, they're housing folks with neurocognitive disorder and chronically difficult behaviors in their state psychiatric hospital, but that's going to be changed and shifting over to a more county-based approach, trying to use mental health nursing specific facilities. That is all I have. I haven't been using the chat. I haven't been monitoring the chat box.
We haven't had any questions come in yet, but let's take
Okay.
a pause. Thank you so much, Reiko. Hongyan did place the links to some of the resources for accessing the forms, and that's in the chat. And if you have questions, you can unmute or you can ask the questions directly.
So I had a quick question just to clarify. So a great talk, so much good information as this unfolds over time. Wondering, you spoke, of course, about providers, a healthcare provider completing the application for the hold, but others can also complete that application, say law enforcement or.
Yeah, I think law enforcement and some mobile crisis teams have the authority to complete a crisis hold.
Okay, thank you. A family asked me if they could complete it. I didn't have the answer for them.
I don't think so. I would think they would have to involve local law enforcement.
Okay, perfect.
My understanding.
Michael Meza, I saw you also come unmuted. Do you want to ask your question?
Sure. I'm not sure if it's a question, but just trying to figure out how we're utilizing it currently. From my perspective, many of these patients coming out from the skilled nursing facility, agitated, hitting staff, hitting other residents, call EMS. Sometimes EMS gives us some pushback that they don't want to take the patient to the ED. They feel like they may not meet criteria, or they feel like the patient has capacity when it's obviously that they do not, and documented well that they do not have capacity. But we're starting to move past that. But once they end up in the ER, this process may take hold, but it's typically pretty brief. And from what I'm hearing in the hospital, it's more like general medical workup to figure out why, if there's any medical conditions that might be contributing to their behaviors. And once that's ruled out, then the hold is discontinued and they're sent back to the SNF, and typically with the same issues that we had before they were sent out the first time.
Yeah, I think a lot of the intent of this legislation was to help keep people from getting quote unquote stuck in an emergency department. But there's still a lot of places where the system is suboptimal for getting folks where they need to go.
And the only last question was the cost. We did have some family concerns when they got a huge bill during this process, and nobody's really familiar with how this is going to work from a cost perspective. Was there some talk at legislative levels that there would be some funding for this?
I think there is no funding for this. And that's why they put the clause in there that individual hospitals can bill insurance and then subsequently pursue costs of the care rendered with patients.
Thank you.
I have a
Great,
question,
thank you.
if that's okay.
Oh, yes, please, Steve.
Oh, wonderful. I'm the assistant director at the Crisis Center here in Southeast Idaho, Region 6 specifically. We do run across folks who may fit in this category. With our case managers, is this something they would need to complete the application before sending to the hospital, or how would that be best on our end, like from case manager, crisis center perspective?
That I'm so if I understand your question correctly, you're in the outpatient setting and you're trying to get someone taken to an emergency department for this evaluation.
Right. A lot of times folks come here voluntary, or they're dropped off by a family member, PD. And so we want to make sure they're getting the right care. And if our case managers feel like this might be related more due to the neurological side of things, how can we best sort that out here at this
Yeah.
crisis
And
centers?
you're at a standalone facility. You're not embedded in an emergency room already. Yeah.
Exactly.
So
We're
I think
convenient.
that, yeah, your case managers would need to fill out the crisis hold
Mhm.
form, and then give that to the EMS personnel who show up, because
Okay.
that would compel them to transport the person to an emergency room.
Perfect. Thank you so much.
Yeah. Yeah.
Great, thank you. I expect all of us will continue to learn through, especially this is all new to Idaho. So we welcome continued questions, continued conversation. Thank you so much, Reiko, for the presentation. Again, Hong Yan put a link for all of our resources, Reiko's PowerPoint, all of that has been placed in the chat, so you can access that at another point. So we're going to wrap up. I wanted to make one quick plug. If you have a case that you would like to present and get recommendations from this amazing panel of subject matter experts, there is a link in the chat for you to submit that case. We welcome that process. We do pay for our cases. We really, really appreciate cases as part of our learning. So thank you. We're going to come back again April 8th from 12:30 to 1:30 Mountain Time. We have a guest presenter, Heather Snyder. She is the Senior Vice President of Medical and Scientific Relations at the Alzheimer's Association, joining us to talk about reducing dementia risk in high-risk populations in Idaho. So we look forward to seeing you in April. Any questions, comments, again, reach out to us. We welcome those. And thank you to all of you for being part of our relaunch of this series. Thanks. Bye.